focus on hospital-acquired pressure ulcers and the role the nurse leader plays in quality health care. These are some of the topics that we will focus on as they pertain to hospital-acquired pressure ulcers. So why does this matter? I want to begin by just putting you in the shoes of someone who experienced a HAPU. I want to read in a clinical exemplar that was written by a neonatal intensive care unit nurse. The names in this story have been changed to protect the privacy of the patient. As a bedside nurse in a level 4 neonatal intensive care unit, I'm often caring for critically ill neonates and their families. One of the things that sets a level 4 NICU apart is their ability to provide life-saving treatments such as extracorporeal membrane oxygenation, ECMO, and therapeutic hypothermia, referred to as cooling in this scenario. It is not uncommon for us to receive a patient that has suffered from meconium aspiration syndrome, which is essentially just inhaling meconium at the time of delivery, and a code event requiring chest compressions and/or intubation afterwards. This type of birth story can result in both ECMO and cooling being indicated for the patient. EM was a little girl born full term to first-time parents. A delivery that was anxiously anticipated turned into a dangerous situation when meconium was present when the mother's membranes ruptured. After hours of attempted labor, a cesarean was called when it was determined to be a failed induction. When EM was pulled from her mother's open body, she let out a quick gasp, inhaling a large amount of meconium. This turned into immediate distress. Oxygenation and ventilation became a huge issue. EM required chest compressions through 2 failed intubation attempts. Once she was successfully intubated, the team worked quickly to stabilize her and move her to the NICU, where she would immediately be put onto the cooling protocol. She would not be placed onto ECMO for another 24 hours, when ultimately her little body would all but succumb to meconium aspiration syndrome. EM, being a very sick patient, received one-on-one nursing care around the clock. A patient who is on both of these therapies is to be turned every 30 minutes, but requires multiple hands to help turn her. For this reason, it is often difficult to stay perfectly on time with these movements. As the hours turned into days and EM responded positively to her many treatments, she became increasingly more stable. Once cooling was complete and she was decannulated from ECMO, the parents were finally able to hold the little girl that they so longed for. The mother, who had handled this hospitalization with such grace, found the pressure ulcer on the back shoulder where EM had laid upon a cord for too long. It was a small spot, but definitely the object of their attention for several days to come. They, along with nursing staff, continued to watch the pressure ulcer as it began showing signs of healing in the coming days. As a nurse, this seemed like it would be the least of their concerns. I thought, this child just survived a traumatic birth, lived through ECMO and cooling, and has minimal long-term complications. But as a parent myself, I understood. This was one thing that didn't need to happen to their baby girl. An insult to injury, this was just one added thing that their precious daughter had to endure. The measurement of hospital-acquired conditions relies on accurate documentation of mandatory hospital-reported present on admission indicators to determine whether the complication presented before or after the patient's admission. This is really important, and this is why a lot of hospitals are going towards a 2-person skin assessment on admission for a new patient, where essentially 2 nurses have to both look at the same patient, check the skin, ensure that they did not come in with any pressure ulcers from outside of the hospital. For this reason, HAPUs are considered to be the most difficult to accurately track and measure, because it relies on annual chart abstraction in order to determine if it has been hospital-acquired or POA, which this is a time-consuming and a not very practical way of looking at measurements, but it still just goes to show how important the documentation is and the accuracy of the documentation for the coding and for the reimbursement. So as the healthcare system is transforming into more of a value-based payment reimbursement system, different payers and healthcare organizations have been looking at the hospital-acquired conditions in order to measure patient safety and assess the quality of care that the patient's receiving. In 2008, the Centers for Medicare and Medicaid Services introduced a claim-level payment penalty that denied an increased reimbursement charge to cover a patient's hospital-acquired condition, which means that if a patient had a pressure ulcer that occurred during a hospitalization, they would not cover the costs it took to take care of that pressure ulcer. The early response of this program initially resulted in a reduction of these types of adverse events and was a huge cost savings in the inpatient setting. So in 2015, the Centers for Medicare and Medicaid Services spearheaded the Hospital Acquired Reduction Program, which calculates a facility-level performance score and adjusts the reimbursed payment to the hospitals in the worst performing quartile. The UVA health system utilizes the National Database of Nursing Quality Indicators, or NDNQI, which is a press-giving database that measures the happy rates over 1,100 hospitals across the United States. According to the most recent data that's available from April to June 2017, the health system had rates that were higher, with a number of 2.07 than the NDNQI mean of 1.78. According to the UVA Health System Quality and Safety Department, in an effort to remedy this quality issue, they have identified best practices for preventing pressure ulcers, such as moving the patient more frequently and incorporating this into their standard work, which means consistently following it every time with every patient. Evidence-based pressure ulcer prevention includes risk assessments and should be followed by a care plan that includes goals and evaluations. The most important risk factor for a patient is immobilization. Studies have revealed that the greatest obstacles to interventions were lack of time, poor communication, lack of knowledge, and inadequate equipment. All of these contribute to the potential for pressure ulcer development. The main way that we can help improve happy rates is by ensuring that the staff have the resources that are needed in order to move their patients. We learned that immobilization is one of the biggest risk factors in developing pressure ulcers. So resources to help move patients can include sufficient staff, mobilization devices, specialty mattresses that are designed for high-risk or bedridden patients. All of these are ways that we can help support the staff so that the staff can better support the patient. Additionally, there are ways to incorporate skin champions or pressure ulcer prevention, otherwise known as PUP teams, into the daily or weekly care of the patients. Also, annual competencies that focus on different pressure ulcer prevention strategies and educating staff can be utilized. Recruiting and getting team members involved is probably the most difficult challenge for the nurse leader. It takes everyone participating together to successfully improve happy rates. There are also budgetary concerns, because all of the necessary strategies to decrease pressure ulcer risks have a financial cost, such as hiring and managing adequate staff or paying to train staff to become skin champions, all the way down to the equipment and devices to safely move patients. All of these factors are important to the budget, so the nurse leader must really make it a priority and focus the budget accordingly. In conclusion, 3 ways to help meet our goal of providing excellent patient care are by maintaining patient safety, performing evidence-based practice, recruiting team members to get involved, and all of these ultimately play into preventing happy use.